I'm sorry I'm late. It's been a really crazy day. I had admission after admission, and then I went to clinic. My interns don't know what they're doing. My attending is incredibly annoyed. All I wanted to do was get out of here on time for once. But here's the sign out. It should be up to date. I told my medical student to work on it. First patient is Mrs. Jones. She's a 45-year-old lady who's admitted with DKA. She was admitted yesterday. She spent an incredible time in the ER before she was transferred up to the ICU. And this is actually her third admission in the past 3 months for DKA. She just doesn't want to take her medication.
It's so frustrating.
Yeah. Her ICU stay was pretty short. She was transferred to us this morning. I really don't know a whole lot about her because I was at clinic all morning. But she's doing pretty well. So for her first problem, she's DKA. I told you that. She's actually doing really well. She's on sub-Q insulin. Her last glucose was less than 300. She's currently taking PO. She's really doing well. And for her UTI...
A UTI? I thought she was just here for DKA.
Yeah, but they think that's what really pushed her over into the DKA. So she's on antibiotics. Did the medical student put them on there? Anyway, she's doing fine. There's really no concerns.
Okay, cool. Sounds pretty straightforward. Does she have any nausea or flank pain?
That's probably the one thing I haven't been called on for her. She's getting a lot of fluid, so any pain that she's having should probably just be flushed out with fluids. Do you have any other questions?
I don't see her antibiotic regimen on here. Or her fluids.
Hold on. Here we go again. Let me answer this, and then I'll finish signing the patients out to you.
Okay, cool.
Hello, I'm Dr. Clifton Yu, the Director of Graduate Medical Education at Walter Reed National Military Medical Center. The handoff scenario you just viewed has become all too familiar. Lack of protected space and time, disorganized presentation with tangential conversation, miscommunications and omissions, and no effort to avoid interruptions. In this training video, we'll review an evidence-based approach to transitions of patient care called I-PASS. But before introducing the I-PASS curriculum and the research study that investigated its use, let's first take a look at some background on the current patient safety movement. In 1999, the Institute of Medicine published a landmark report entitled "To Err is Human, Building a Safer Healthcare System," indicating that 44,000 to 98,000 deaths per year were caused by medical error. In a more recent report in 2010 from the Department of Health and Human Services, the number of deaths due to medical error was revised upwards to 180,000 per year. This makes medical error the fourth leading cause of death in the U.S. So what is the root cause of these medical errors? To answer that question, the Joint Commission reviewed all Sentinel events reported voluntarily over a 10-year period. Sentinel events are unexpected occurrences involving death or serious physical or psychological injury. Using root cause analysis to determine contributing factors, they found that miscommunication was a cause in nearly 2/3 of all cases. Ironically, the finding that failures in communication are the major root cause of Sentinel events came right in the middle of an ongoing debate over the negative effects on patient safety of extended work hours for resident physicians. This debate culminated in the most recent work hour restrictions mandated in 2010 by the Accreditation Council on Graduate Medical Education, or ACGME, requiring, among other rules, no more than 16 consecutive hours for interns. So on the one hand, we have communication failures as the number one cause of Sentinel events, and on the other hand, we have decreased shift lengths and increased transitions of care. Let's add a third problem to the mix. Although the ACGME now requires both training in and monitoring of handoffs, handoff skills are still largely learned on the job and without feedback. This is largely true regardless of whether the handoffs are being performed between doctors, nurses, or other members of the healthcare team. So how do we solve this patient safety crisis? In 2010, the I-PASS study was launched as part of a collaborative effort led by Boston Children's Hospital and involving 11 academic institutions. The purpose of this multi-center study was to determine the effectiveness of a package of curricular interventions called the I-PASS Handoff Bundle in standardizing and improving handoffs of care. After reviewing over 11,000 patient admissions over a 3-year period, the researchers found that medical errors decreased by 28%, and preventable adverse events decreased by 34% across all institutions after implementation of the handoff bundle. The I-PASS Handoff Bundle consists of 3 major elements: training in team communication using the TeamSTEPPS program, a standardized verbal mnemonic, and a corresponding written handoff document. In the next few moments, I'll discuss all 3 elements with an emphasis on the I-PASS mnemonic. TeamSTEPPS stands for Team Strategies and Tools to Enhance Performance and Patient Safety. It's an evidence-based teamwork training program designed for healthcare professionals by the Department of Defense Patient Safety Program and the Agency for Healthcare Research and Quality. For the purpose of the I-PASS curriculum, we selected 7 TeamSTEPPS communication techniques most relevant to hospital teams. The brief is used to plan team activities, for example, immediately before or after team rounds. The debrief is used to analyze an interim event, for example, a recap of events at the end of a shift. The huddle is used to problem solve, for example, after a change in patient status or planning for a procedure. Cross-monitoring and feedback is used to ensure patient safety and improve team performance. Advocacy and assertion is used by all team members to advocate for safe care, regardless of position on the team, for example, in recognizing a potential error. Checkback is used to ensure accurate transfer of information, for example, reading back a verbal order to ensure accuracy. And lastly, the handoff itself is used to transfer not only information, but also responsibility for the patient. You can learn more about each of these communication strategies in the full I-PASS curriculum or via TeamSTEPPS as it's rolled out on your individual units. Regardless of which tool is used, all of the TeamSTEPPS communication techniques serve to build a shared mental model amongst team members. In other words, to attain that sense of, are you thinking what I'm thinking? For example, have you ever had an experience where different members of the same team left a verbal handoff with vastly different impressions of who the sickest patients were, or even what the overall plan of action was? Team effectiveness will improve if all members of a team have a shared understanding of the situation. The next part of the I-PASS Handoff bundle is a standardized I-PASS verbal mnemonic. As I review the mnemonic, think to yourselves, how are these elements different from what your clinical service is already using? I-PASS stands for illness severity, patient summary, action list, situation awareness and contingency planning, and synthesis by receiver. A mnemonic provides an easy-to-remember organizational framework with standard language and sequence. Let's see how I-PASS works in practice. In the next video, you'll see an ideal handoff between internal medicine residents who are discussing the same diabetic ketoacidosis patient from the poor handoff you viewed before.
All right, I made it over from clinic just in time. I put a sign on the door to let the nurses know that we're giving handoff now.
Great, that should help with interruptions. So we have a census of 12 patients, 2 are watchers, and 1's coming up from the emergency room. The interns have updated the sign out, and I just finished editing it. Here you go.
All right, great, let's do this.
Okay, so we're gonna start on one of our most unstable patients, one of the watchers, Miss Jones. She's a full code. So Miss Jones is a 45-year-old female with a past medical history of type 1 diabetes who was admitted yesterday for DKA and sepsis secondary to a UTI. She was initially admitted to ICU where she was started on an insulin drip, aggressive hydration, and started on ceftriaxone for her UTI. She quickly recovered in the ICU and was able to be transferred to the medicine floor in stable condition for continued management of her glycemic control, treatment of her UTI, and electrolyte monitoring. So going by problems, first, for glycemic control, she's tolerating sub-Q insulin, 15 units of aspart AC, and she'll start 40 units of glargine tonight. Her last blood glucose 1 hour ago was 233. She's still on normal saline at 200 cc's an hour. She received 8 liters total over her hospital course, and she hasn't had any respiratory issues, and her exam is completely unremarkable for signs of volume overload. Next is urosepsis. Her fever has resolved. Leukocytosis is down. It was 24,000 on admission. She's down to 15,000 today. Hypotension has resolved, and she's not tachycardic anymore. Blood and urine cultures are pending. Finally, her electrolyte issues. Her electrolytes are stable. Her numbers this time are sodium is 138, potassium's 4.3, phosphorus is 3.0, magnesium's 2.1, and her anion gap this morning was 12. It's down from 24 on admission. She's getting Q4-hour BMPs, and the next one is due at 8 p.m.
Before you get to the action list, when did you guys switch from IV insulin to sub-Q insulin?
Good question. So we did that at 7 a.m. this morning, just prior to breakfast.
Great.
So things for you to do tonight. First, make sure the glargine gets started. Second, follow up on that 8 p.m. BMP to make sure that the anion gap is downtrending, and replete her electrolytes. We're looking for potassium greater than 4, phos greater than 3, mag greater than 2. Lastly is to monitor her respiratory status, knowing that she's gotten 8 liters of fluid during this hospitalization. So for contingency planning, if her anion gap is increased, she'll need to be transferred to the ICU. The ICU is aware of her.
Great.
If she develops shortness of breath, get a stat chest x-ray, give her IV Lasix 40 mg times 1 if you think it's clinically indicated. Lastly, if she develops a fever greater than 101 degrees Fahrenheit, please obtain urine and blood cultures, and I brought in her antibiotics to Zosyn.
Okay. So let's make sure that I've got everything clear. A 45-year-old type 1 diabetic, status post DKA and sepsis in the setting of a UTI. She's on sub-Q insulin and still on fluids. If she develops any respiratory distress, I'll consider possible fluid overload. She's getting ceftriaxone for the UTI right now. If she has another fever, we'll reculture and add Zosyn. Her next BMP is at 8 o'clock. We'll maintain her electrolytes in the range you indicated and transfer to the ICU if her acidosis worsens. Would you get an ABG if she has shortness of breath?
It's not a bad idea. She will probably have a mixed picture secondary to her resolving metabolic acidosis.
Okay.
Do you have any other questions?
No?
Okay, let's go on to the next watcher.
Okay.
Now, let's dissect this handoff, looking at each of the 5 elements of I-PASS individually. We'll start with illness severity. In I-PASS, illness severity is a continuum: stable, watcher, and unstable. A watcher is a patient who any clinician has a gut feeling is at risk of deterioration, or who is on the verge of potential decompensation. In this scenario, the resident giving the handoff provides her receiver first with a high-level overview of the patient's census, and then specifies the illness severity of the DKA patient. This standard language appropriately focuses the receiver's attention.
All right, I made it over from clinic just in time. I put a sign on the door to let the nurses know that we're giving handoff now.
Great, that should help with interruptions. So we have a census of 12 patients, 2 are watchers, and 1's coming up from the emergency room. The interns have updated the sign out, and I just finished editing it. Here you go.
All right, great, let's do this.
Okay, so we're gonna start on one of our most unstable patients, one of the watchers, Miss Jones. She's a full code.
The next element of the I-PASS handoff process is the patient summary. In general, there are 5 sections to the patient summary: summary statement, events leading up to admission, hospital course, ongoing assessment, and plan. The summary statement is the one-liner that sets the clinical context and contains critical identifying information such as name, age, gender, and pertinent past medical history. The events leading up to admission section includes the essential history, physical exam, and lab findings in chronological order. The hospital course provides a section for key findings, changes in status, events, or special considerations or concerns. Both the events leading up to admission and the hospital course may be written in bullet point form and can be truncated when a high level of diagnostic certainty is attained. The last 2 sections, ongoing assessment and plan, offer a differential diagnosis with a global plan for the entire hospital stay. These sections may be organized by problems, as you saw the resident do in this scenario, or by systems. The problem-based or systems-based approach may vary depending on patient complexity, patient setting, or institutional culture. Ultimately, an effective patient summary should create a shared mental model amongst giver and receiver.
So Ms. Jones is a 45-year-old female with a past medical history of type 1 diabetes who was admitted yesterday for DKA and sepsis secondary to a UTI. She was initially admitted to ICU where she was started on an insulin drip, aggressive hydration, and started on ceftriaxone for her UTI. She quickly recovered in the ICU and was able to be transferred to the medicine floor in stable condition for continued management of her glycemic control, treatment of her UTI, and electrolyte monitoring. So going by problems, first, for glycemic control, she's tolerating sub-Q insulin, 15 units of aspart AC, and she'll start 40 units of glargine tonight. Her last blood glucose 1 hour ago was 233. She's still on normal saline at 200 cc's an hour. She received 8 liters total over her hospital course, and she hasn't had any respiratory issues, and her exam is completely unremarkable for signs of volume overload.
Whereas the patient summary creates a shared understanding so that the next caregiver is prepared to carry out the treatment plan, the action list actually specifies what needs to be done. Here's the action list for a DKA patient. It includes specific to-do items with attention to timeline, level of priority, and assigned responsibilities. If no action items are anticipated, clearly specify nothing to do. Let's take another look at how this was conveyed in our scenario.
So things for you to do tonight. First, make sure the glargine gets started. Second, follow up on that 8 p.m. BMP to make sure that the anion gap is downtrending, and replete her electrolytes. We're looking for potassium greater than 4, phos greater than 3, mag greater than 2. Lastly is to monitor her respiratory status, knowing that she's gotten 8 liters of fluid during this hospitalization.
While the action list indicates what the receiving resident must do over the next shift, the next I-PASS element, situation awareness and contingency planning, indicates what the receiving resident may need to do. Contingency plans allow the patient care team to problem solve before things go wrong, to anticipate changes in patient status and respond appropriately. In our example case, if she develops a fever, then reculture blood and urine. You should list interventions that have or haven't worked and identify resources. Provide detail based on your receiver's level of expertise, knowledge of disease process, and familiarity with the patient.
So for contingency planning, if her any gap is increased, she'll need to be transferred to the ICU. The ICU is aware of her.
Great.
If she develops shortness of breath, get a stat chest x-ray, give her IV Lasix 40 mg times 1 if you think it's clinically indicated. Lastly, if she develops a fever greater than 101 degrees Fahrenheit, please obtain urine and blood cultures, and I brought in her antibiotics to Zosyn.
While contingency planning should be considered on every patient, it is completely permissible on stable patients to mention that one doesn't anticipate decompensation. The final element of I-PASS, synthesis by receiver, reflects the TeamSTEPPS technique of checkback. Synthesis by receiver is a brief restatement of essential handoff information in a cogent summary. It provides an opportunity for the receiver to clarify elements of the handoff, ensure there is a clear understanding, and have an active role in the handoff process. Synthesis by receiver promotes a shared mental model by demonstrating that information is received and understood.
So let's make sure that I've got everything clear. A 45-year-old type 1 diabetic, status post DKA and sepsis in the setting of a UTI. She's on sub-Q insulin and still on fluids. If she develops any respiratory distress, I'll consider possible fluid overload. She's getting ceftriaxone for the UTI right now. If she has another fever, we'll reculture and add Zosyn. Her next BMP is at 8 o'clock. We'll maintain her electrolytes in the range you indicated and transfer to the ICU if her acidosis worsens. Would you get an ABG if she has shortness of breath?
It's not a bad idea. She will probably have a mixed picture secondary to her resolving metabolic acidosis.
Okay.
Do you have any other questions?
No?
Okay, let's go into the next watcher.
Okay.
To summarize, the elements of the I-PASS mnemonic are illness severity, patient summary, action list, situation awareness and contingency planning, and synthesis by receiver. Now, let's watch a handoff of multiple patients on a surgical service. The giver of the handoff is from the day team, and the receiver is from the night float team, so the patients are familiar to both. Because of this familiarity, you'll notice that the residents in the handoff use a more abbreviated form of I-PASS, but the 5 key elements remain.
Hey Michelle, how was your day?
Not bad, not bad. I've got some updates for you since your shift last night.
All right, let's hear it.
Okay, I'll start with the sickest patient. He'll be someone to watch tonight. You remember Mr. Everson, right? He's the 58-year-old who had the right hemicolectomy 2 days ago for colon cancer.
I do know him well.
Yeah. So, unfortunately, this morning he became tachycardic with a spike in his white count. We suspected a leak, and we took him back to the OR, and we did find a small leak at his anastomosis site. He underwent another resection, reanastomosis, and has a diverting loop ileostomy. He got out of the OR about 3 hours ago and is now extubated and awake on the ward. He's got 2 drains in place, and they're putting out serosanguinous fluid, and he's NPO with an NG tube. Please do a post-op check on him tonight and make sure that his ostomy and drain output look okay. He also has post-op labs scheduled for 9 o'clock tonight.
All right. Do you happen to know if his ostomy has put out anything since the OR?
It has. It looks good as about an hour ago. For contingency planning, if his ostomy turns purple or black, though, he may need to go back to the OR for a revision.
Okay, so 58-year-old male who's 2 days now status post a right hemicolectomy and now 3-hour status post revision for a leak. Mm-hmm. I'll follow up on his labs tonight and check on his ostomy. If he shows any signs of necrosis, we'll need to go back to the OR.
Right, exactly.
Okay.
We also have 2 new patients. They're both stable. The first one is Mr. Tucci. He's a healthy 23-year-old male, laparoscopic bilateral inguinal hernia repair. His case just finished about 30 minutes ago, and he already looks great, and he's set up to go home. His discharge summary is done. His discharge meds are in. There isn't anything for you to do for him, but if you do get paged, then please check on him and make sure that he's ready to go home.
Okay, so 23-year-old status post laparoscopic bilateral inguinal hernia repair, just needs a bed check tonight.
Exactly. And then the second new patient is Mrs. Engel. She's a 40-year-old who underwent a left mastectomy for 2-centimeter breast cancer today. Her surgery went great. Plastics placed a tissue expander, and she's got 2 small drains in place. She's been on the ward a few hours now. She's doing very well. She's got a PCA for pain. Tonight, please just do a post-op check on her and check on her pain. If we can transition her to oral meds, then there's a chance she may be able to go home tomorrow. Also, please check her drain output. If it dramatically increases or she has any other evidence of a hematoma or a bleed, then she may have an indication to go back to the operating room.
All right, so status post left mastectomy seems to be doing well. You just want me to check on her pain and her drain output tonight. Seems like likely discharge in the morning.
Exactly,
Okay.
right.
Does she have any other health problems I should be aware of?
Good question. Only mild hypertension. She usually takes lisinopril. It's on the med list right here.
Ah, got it. All right, sounds good. Just kind of looking over this. It seems like the other ones I know, right?
Right, exactly. So Mr. Jones, you admitted him last night for the small bowel obstruction. He's doing great. He passed gas this morning and he's self-progressing on his diet. He hasn't had any issues. Just monitor his pain with eating tonight. He'll probably go home tomorrow as long as his pain doesn't recur. But if he does have nausea, then don't hesitate to stop his diet, get IV fluids, and get a KUB to see if he's recurred.
All right, so recovering small bowel obstruction, doing well, self-progressing his diet. I just need to check on any postprandial pain.
Exactly. And the last is Mrs. Lee. She's doing very well from her open cholecystectomy 2 days ago. We transitioned her from IV to oral pain medications today, and she hasn't had any issues thus far. But please check on her pain tonight. If her pain does recur, then I think about a bile leak for her just because she was an especially difficult case. If that happens, then repeat her labs and consider a HIDA scan if you're suspicious.
All right, so post-op open chole now on PO pain meds, but you guys think if she does have a pain recurrence that we should be suspicious for a bile leak.
Right, exactly.
All right, seems like I got it covered. I'll see you bright and early.
Okay, see you
All
tomorrow.
right, bye.
Returning to our handoff bundle, the final part is the printed handoff document. The printed handoff document supplements the verbal handoff and should be organized according to the I-PASS mnemonic, as shown in this example. The printed document allows the receiver to follow the handoff, but may provide more comprehensive information than what's presented verbally. It's therefore important that it's updated daily and checked for accuracy. So now you've seen the 3 main components of the I-PASS Handoff Bundle: team communication training, a standardized verbal mnemonic, and a corresponding printed handoff document. Keep in mind that although these are the central components of the I-PASS Handoff Bundle taught explicitly in the core I-PASS workshop, there are other aspects of the full I-PASS curriculum that are essential for acquisition and maintenance of these handoff skills. There's a faculty development and observation program designed to provide evaluation and feedback, simulation exercises, and just-in-time training for educational reinforcement. And finally, an I-PASS campaign designed to promote organizational sustainability. By implementing all or even some of the aspects of the I-PASS Handoff curriculum, we hope that your clinical service will achieve a decrease in communication errors, enhancement in situational awareness, and ultimately improvements in patient safety.